Welcome back to the deep dive.
Great to be here.
So today we're looking at diabetic foot disease. It's a really significant issue for anyone managing diabetes.
Absolutely. A major complication.
Yeah.
And we're drawing from the 2015 NEE guidelines for this one.
Right. And the goal is pretty straightforward. Pull out the key information you need to know quickly and effectively. Sort of a high-yield overview.
Exactly. Get the essentials down.
Okay, so let's start right at the beginning. What exactly is diabetic foot disease and, what's causing it?
Well, fundamentally, it's damage to the feet happening because of diabetes. There are two main underlying problems working together, usually.
Two main things.
Yeah. First off, there's neuropathy.
Nerve damage, right?
Precisely. Diabetes can damage the nerves, especially in the feet, leading to a loss of protective sensation. So you might not feel a small stone in your shoe or a cut.
Which obviously sounds risky.
It is. It also causes skin to become dry and prone to cracking, and in some cases can lead to changes in the foot's actual shape, something called Charcot'sarthropathy.
Okay, nerve damage is one. What's the other factor?
The other big one is peripheral arterial disease, or PAD.
Ah, so problems with blood flow.
Exactly. Diabetes is a major risk factor for atherosclerosis, the narrowing of arteries. This affects both the larger arteries and the tiny microvessels in the feet.
So less blood gets through.
Right. We call that ischemia. It means the tissues don't get enough oxygen or nutrients, which makes healing very difficult, and the foot much more vulnerable.
Okay, so we have nerve damage and poor blood flow. How would these actually show up? What might someone or their doctor notice?
Well, with neuropathy, the main sign is that reduced sensation. Difficulty feeling light touch, maybe temperature changes.
And for the blood flow, the ischemia.
A clinician might find that the pulses in the feet, the dorsalis pedis on top and the posterior tibial by the ankle, are weak or even absent.
Okay.
They might also measure something called the ankle brachial pressure index, the ABPI, which can be lower. And sometimes people experience pain in their calves when walking that eases with rest. It's intermittent claudication.
And if these underlying issues aren't picked up or managed, what kind of complications are we talking about?
Quite a few, unfortunately. You can get calluses, thick, hard skin due to pressure changes from neuropathy or deformity. These can then break down and form ulcers, which are open sores.
Which are prone to infection, I imagine.
Very much so. Infections like cellulitis, which is skin infection, or even osteomyelitis, where the infection gets into the bone, and Charcot'sarthropathy can cause major foot deformities. In the worst cases, it can lead to gangrene.
That all sounds incredibly serious. So screening becomes really important. How do the NICE guidelines say we should screen for this?
The key recommendation is annual screening for everyone with diabetes. It's crucial.
Every year. And what does that involve?
Well, for ischemia, it involves checking those foot pulses, manually feeling for the dorsalis pedis and posterior tibial arteries.
Okay.
And for neuropathy, the standard test is using a 10-gram monofilament. It's a thin nylon thread applied to specific spots on the sole of the foot to check if the person can feel it.
Right, that little filament test. Okay, so after the screening, how is risk assessed?
NICE provides a clear risk stratification. It helps decide how often someone needs checking and by whom.
How does that break down?
So low risk basically means no risk factors are present, though they might have simple calluses.
Okay.
Moderate risk is if someone has a foot deformity or neuropathy or non-critical limb ischemia, meaning reduced blood flow, but not immediately threatening the limb.
And high risk?
High risk involves things like having had a previous ulcer or amputation, being on renal replacement therapy like dialysis, or combinations like having neuropathy plus deformity or calluses, or having ischemia plus deformity or calluses.
So the combination really bumps up the risk level.
Exactly. It shows how these factors interact.
So what happens for people identified as moderate or high risk?
The guidance is clear. They need regular follow-up with a specialist diabetic foot service or center. Managing anything beyond simple calluses, especially in moderate or high-risk individuals, gets complex and needs that expert team approach.
Right, makes sense. So wrapping this up then, this deep dive into the NICE guidelines really underscores how vital regular annual foot checks are for everyone with diabetes.
Definitely. Identifying that nerve damage or poor circulation early And understanding your personal risk level based on those checks is absolutely key to preventing these potentially very serious complications.
It's about proactive management and prevention.
Absolutely. Awareness and regular checks are your best defense.
Well, that's been really insightful. For anyone wanting to explore further resources or revision materials, do check out pastthemsra.com and also freemessra.com.
Great resources.
Thanks for joining us on the Deep Dive.